Welcome to this advanced module on Transmission-Based Precautions, or TBPs. As clinicians, we recognize that standard precautions are our baseline. However, TBPs constitute the second tier of infection control. Our objective today is to move beyond basic protocols into the biophysics of pathogen transmission and the rigorous engineering standards required to protect our patients and ourselves in high-risk clinical environments. Slide 2. The Stratified Defense Architecture. Hospital infection control is built on a stratified defense. Standard precautions are risk-agnostic and applied universally to all patients. TBPs, however, are additive, not substitutive. They are activated upon clinical suspicion, such as a chronic productive cough or unexplained vesicular rash, rather than awaiting microbiological confirmation. This proactive trigger system is essential to prevent the epidemiological chain from establishing a foothold in our wards. Slide 3. Biophysics of transmission modes. To understand precautions, we must understand particle dynamics. Macro transmission via fomites involves indirect contact with contaminated devices like stethoscopes. Mesotransmission involves large droplets, greater than 5 microns, which are propelled short distances, typically under 3 feet, and undergo rapid gravitational fallout. Finally, microtransmission involves droplet nuclei of 5 microns or less. These remain viable and suspended in ambient air currents for extended periods, bypassing the spatial limits of droplet transmission. Slide 4. Contact precautions, the Vanguard Protocol. Contact precautions target both direct skin-to-skin transfer and indirect transfer via contaminated surfaces. Our focus matrix includes MDROs like MRSA and carbapenem-resistant Enterobacteriaceae, CRE, enteric pathogens such as C. difficile and rotavirus, and integumentary infestations like scabies. For MDs, the clinical imperative is the recognition that the environment itself becomes a reservoir for these vanguard pathogens. Slide 5. Contact precautions, spatial and clinical implementation. While single rooms are preferred, cohorting patients with identical pathogens is an acceptable alternative if we maintain a minimum 3-foot separation and utilize privacy curtains as physical barriers. A critical MD-level nuance. For C. difficile, alcohol-based hand rubs are insufficient against spores. A 4% chlorhexidine hand wash or soap and water is mandatory to ensure mechanical removal of the pathogen. Slide 6. Droplet precautions, intercepting respiratory vectors. Droplet precautions manage pathogens like Neisseria meningitidis, Haemophilus influenzae type B, and influenza. These particles do not remain suspended in the air. Therefore, the 3-foot rule defines our primary blast radius. However, recent CDC guidance suggests that for highly infectious agents, extending this caution to 6 or 10 feet upon room entry may be prudent, as the initial velocity of a cough can propel droplets further than previously modeled. Slide 7. Droplet precautions, source control, and PPE. For healthcare worker protection, a surgical mask is mandatory for close contact. Source control is equally vital. If a patient must be transported, they must wear a surgical mask to contain secretions at the source. Unlike airborne precautions, droplet precautions do not require specialized air handling, as the weight of the particles leads to rapid deposition on environmental surfaces, necessitating frequent disinfection of high-touch areas. Slide 8. Airborne precautions, the invisible threat. The invisible threat involves aerosol-transmissible diseases, ATDs, like Mycobacterium tuberculosis, measles, and varicella. These droplet nuclei stay suspended for hours and travel along HVAC currents. Standard surgical masks fail here because they lack the peripheral seal and filtration density to intercept particles at this micron level. Airborne isolation is a marriage of personal protection and high-level architectural engineering. Slide 9. Aerosol-Generating Procedures, AGPs, are risk multipliers. Procedures such as endotracheal intubation, open suctioning, bronchoscopy, and even CPR generate much higher concentrations of airborne particles than standard respiration. Even if a patient is not on baseline airborne precautions, the performance of an AGP mandates the immediate use of an N95 respirator and, ideally, a negative pressure environment to mitigate the surge in infectious aerosols. Slide 10. Engineering controls. The AIIR blueprint, the Airborne Infection Isolation Room, or AIIR, is defined by 4 metrics. First, a minimum of 12 air changes per hour, ACH, for new construction. Second, a negative pressure differential of at least 2.5 pascals relative to the hallway. Third, precise sealing with a maximum leakage area under the door of 0.5 square feet. Finally, a clean to dirty airflow that ensures air moves from the HCW toward the patient and then directly to the exhaust. Slide 11. AIIR adjuncts, filtration, and UVGI. When mechanical ventilation cannot meet the 12 ACH standard, we utilize adjuncts. HEPA filtration is required for air exhausted directly to the outside. Upper room ultraviolet germicidal irradiation, or UVGI, creates a violet kill zone above 2.5 meters. For UVGI to be effective, lamps must be checked every 6 months, and the air must be mechanically moved through the irradiation zone to ensure a 99% kill rate for M. tuberculosis within 2 minutes. Slide 12. Natural versus mechanical ventilation alternatives. In resource-limited settings, natural cross-ventilation can be adapted. The key is clinical positioning. The HCW should always sit upwind near the fresh air supply, while the patient is positioned downwind near the exhaust window. While less controlled than mechanical negative pressure, this unidirectional flow significantly reduces the HCW's inhalation risk by carrying infectious particles away from the breathing zone. Surgical masks. The distinction between a surgical mask and an N95 is foundational. Surgical masks utilize mechanical impaction to block splashes. N95 respirators combine mechanical filtration with electrostatic capture to trap 95% of small aerosol nuclei. For the N95 to function, it must have a perfect peripheral seal. This requires annual formal fit testing and a user seal check by the clinician every single time the device is donned. Slide 14. Synthesis. The TBP application matrix. This matrix synthesizes our protocols. Note that hand hygiene is the universal constant. Contact precautions mandate gloves and gowns. Droplet precautions mandate the surgical mask. Airborne precautions mandate the N95 and negative pressure. A critical reminder for MDs, PPE is our final barrier, but it is only as effective as the sequence in which it is donned and, more importantly, doffed to prevent self-contamination. Slide 15. Conclusion and operational imperatives. In conclusion, holistic infection control rests on 3 pillars. First, unbroken foundations in standard precautions. Second, agile recognition, initiating isolation at the moment of suspicion. Third, structural fidelity, ensuring our AIIRs and PPE meet the engineering and fit standards discussed today. We are the stewards of this environment. Our adherence dictates the safety of the entire facility.